Welcome to 2-minute anaesthesia in critical care. Today we're going to discuss the key considerations around aminophylline infusions with reference to initiating infusions, maintenance of those infusions and key side effects. Let's get started. So aminophylline is administered via the intravenous route in patients with acute bronchoconstriction with reversible airway obstruction. Once administered, it dissociates into two key components, theophylline but also ethylenediamine. Theophylline is the key active component which moves around the body and has systemic effects. In the lungs, it causes bronchodilation. In the heart, it increases heart rate and contractility. It has widespread CNS effects, but also it can cause a mild diuresis in the kidneys. The exact mechanism of action is not fully understood, but it may involve competitive inhibition of phosphodiesterase 3 and 4, increasing cyclic AMP levels and therefore leading to relaxation. It also antagonizes adenosine A to B receptors, therefore blocking adenosine-mediated bronchoconstriction and therefore inflammation. Now let's just recap the differences between theophylline and aminophylline. This table compares the two key drugs, so theophylline and aminophylline. Theophylline is the active compound which is purely water soluble and therefore given by the oral route. It has extensive hepatic metabolism. In comparison, aminophylline has higher water solubility due to its salt complex of theophylline and ethylenediamine. It's usually given by the intravenous route but also can be given by the oral route. Now let's discuss aminophylline infusions. It's usually dosed based on ideal body weight as aminophylline poorly distributes in fat. In patients who are not already on theophylline, they may require a loading dose of 5 mg per kilo intravenously over 20 to 30 minutes. This is followed by a maintenance infusion of 0.5 to 0.7 mg per kilo per hour. Patients may require dose adjustment based on comorbidities. It's always given by the intravenous line. Therapeutic effects of theophylline are between 10 to 20 mg per litre. Significant side effects can be observed at higher concentrations, and these can be split into 4 systems: gastrointestinal, vomiting, abdominal pain, diarrhea; neurological, agitation to low conscious levels to seizures; cardiovascular, to profound tachycardias, arrhythmias, hypotension; and also metabolic, hypokalemia, magnesemia, calcemia, and high levels of glucose. Plasma theophylline levels are usually checked 4 to 6 hours after IV loading or once every 24 hours once steady state is achieved. Dose infusion adjustments may be indicated in patients with a poor response in the absence of clinical features suggestive of toxicity. Theophylline is mainly metabolized by cytochrome 1A2, but at high concentrations may involve 2E1. The half-life is relatively short, in children 3 to 5 hours, in adults 8 hours. However, clearance can be significantly reduced due to multiple factors which will be discussed on the next slide. This table highlights the key considerations leading to reduced clearance of the drug and therefore high plasma concentrations, for example in extremes of age, liver, heart failure, sepsis. In addition to factors that lead to increased clearance and therefore lower plasma concentrations. Examples include smoking, drug interactions and hypothyroidism. And finally, this table summarises the key considerations. Once again, thank you for watching.